All right, so we are talking about shoulder instability here. And so we can go into clinical pattern recognition. Of course, pain patterns may or may not be predictive of the source structure or source pathology. But commonly, patients complain of an aching, deep, catching, clicking, or apprehension at end ranges. So you notice this pattern here. And the instability, shoulder pain with movement coordination impairments, that can include, of course, labral tears, slap lesions, Bankart lesions, anterior or multi-directional instability. And the reason why these are grouped together is because generally your management is going to be similar. Unless it's post-op, then you might have different contraindications or precautions to worry about. And you can see in the information button here that there's just a brief description of what this instability might involve. So if we go into the actual pattern, you can look at the prevalence of these types of conditions. And you note that really the risk of dislocation and also dislocation in general seems to occur in the younger group, right? So the more active group, this group is also more prone to redislocation. There is a double peak, you note here in this first line, second and sixth decade. So in the 20s and in the 60s, it seems to happen again. Perhaps in the 60s, people are falling a lot more. Right? So when you watch the video, you can see apprehension. The patient goes into these common positions that put the capsule on stretch. These are positions of instability, and so a very common feature of this particular pattern is patients telling you that they're scared to go to certain positions. People with frozen shoulder, they just can't move, or they're just really, really painful, and that could be the early stages of frozen shoulder. But in this case, unlike a impingement where a patient usually can get into full ranges of motion and they may have an arc of pain, this person says, I have difficulty coming into these particular positions that are my instability positions. So you can read about that more here in the reported findings and examination findings. All right, so what should I do when I do my physical exam? Well, under the key findings, you'll see that often you'll see apprehension during active range of motion. During your assessment of joint mobility, you might see excessive anterior glide. Of course, there's other directions that you could be unstable in as well, but in the vast majority of patients, you're going to see hypermobility in the anterior glide direction. And we've organized the test in instability test. You can watch these on your own: sulcus sign, jerk test, anterior apprehension relocation test, and labral tear test. We've tried to trim out how many tests that are actually involved here. And you can also see that we've given you some options if the patient is very, very painful, some very gentle things that are safe for the patient to do initially if they are pain limited. When you look at the movement faults, the interesting part is that the same types of movement faults that may occur in any type of shoulder pathology are ones that we have to consider for this patient as well. Yes, they may be unstable. Yes, this may be the main thing you're worried about, this instability position, the positions, but what are the things that might have led to this patient becoming unstable? Of course, it could be traumatic, but it could be repetitive motions of pitching, of throwing, of overhead activities that include scapular faults. You see the three main scapular faults. We use these same faults in all the shoulder conditions: insufficient scapular upward rotation and elevation, insufficient scapular posterior tipping, and excessive scapular winging or internal rotation during active elevation or elevation of the arm. So you can watch these videos of postural exam, the special test to test if this is truly involved in this patient's asterisk sign, and then some muscle testing that might be relevant. You can see lower trap, serratus anterior, upper trap. Right? And when you look at associated impairments, you'll see that we have included a number of thoracic spine assessments, because commonly the thoracic spine is stiff in these athletes. Some upper quarter muscle length tests that could influence the humerus. And of course, checking neurodynamic assessment in case there's a nerve condition, neurodynamic condition contributing to the patient's symptoms. And some picture-specific impairments. Here you see GERD, assessment for GERD, In some pictures, insufficient thoracic flexion, so they're actually pretty stiff. They have a flat back. Posterior shoulder endurance test. You can see the sensitivity and specificity data there. And also, because these athletes often spend time on a single limb at some phase of their sport, you can see some single limb balance, star excursion balance test, and also a closed kinetic chain upper extremity stability test. So these are all tests that are relevant for these high-level athletes. Don't forget that we've added in the differential diagnosis for you to try to rule out other potential conditions. For example, if a patient says, I have no history of dislocation or subluxation, it helps you to differential out that this is not an instability, or they do not have apprehension with testing. You can see that. And they have intact and strong rotator cuff muscles. If they say, actually, rotator cuff testing really brings on my pain, you might consider that this painful shoulder may not be, right, a instability problem. And of course, clearing out the cervical spine. When it comes to interventions, you can always watch a clinical reasoning video, right? A lot of these interventions revolve around motor control training with helping the shoulder function in a precise way. From a manual therapy standpoint, we've organized the interventions based on irritability. If they're highly irritable, you want to do short arcs of passive range of motion that are pain-free and stay out of the apprehension positions. In the moderate irritability, you want to begin to restore ranges of motion, particularly in this case posterior and inferior glides. Unless in this case the inferior glide is already hypermobile, you would have deemed that or noticed that in your assessment and you would not treat that. Okay, and you can also improve shoulder girdle mobility. There are also techniques to improve thoracic mobility, improve soft tissue mobility. You can see stretching and soft tissue mobilizations to the humeral medial rotators, the humeral anterior tippers like the pec minor, and some posterior capsule stretching that is very typical as we work with these high-level athletes. Your therapeutic exercises will match those. You may be, again, stratified by irritability, some high irritability exercises to reduce their pain, some moderate irritability exercises to improve range of motion. And if you notice under improving thoracic mobility, depending on what you see on your patient, you may need to improve their thoracic flexion or improve their thoracic extension. And for motor coordination, how do we improve the position of the scapula? How do we improve the function of the scapula? You can see a number of different exercises here. And how do I improve precision of the throwing motion? This is a test to observe faulty movements and also a treatment. Ultimately, we want to restore these patients back to function, and you can see a progression of return to throwing here described. And finally, there is patient education so that your patients will be able to be informed about what's going on, how long will it take, what we are going to do in physical therapy, and what you can do to help yourself. All right, so I hope that helps, gives you a quick tour of how to get your thinking set and how to manage these patients with shoulder instability or shoulder instability with movement coordination impairments. Ultimately, the management of these patients involves trying to help that joint stay closer to the middle, to be able to move precisely in the middle, in neutral, so that structures around it do not continue to get stressed. All right, hope you guys enjoyed that, and check out the apps at PhysioU.com.